Good afternoon, all the delegates and faculties, and it's always nice to have Professor UG here, and welcome to India. And so elastography has been most widely used amongst the EUS colleagues, and of late for the past decade we have this technology even with EBUS, but unfortunately this technology hasn't been so promising or did not add much of utility to our routine clinical practice, though in selected cases we do find utility of your elastography. So I'll just touch upon few of the basic aspects of the elastography, and we'll see how it really helps in our routine clinical practice and in what way we generally use elastography in our practice. So So we know that it's just an add-on to our routine EBUS endobronchial ultrasound, so it's a non-invasive method. So basically what we do is we try to understand the elasticity of the tissue within the scanned area, and it was reconstructed by image processing, and we compare it with the surrounding tissue. So it helps us to understand the relative stiffness of the tissue, which can be mapped either in the form of a color map, or you can have a shear wave velocity. So the basics of elastography, what we need to understand is the elastography relies upon the movement and the compression deformation of the observed tissues, and with respect to the lung, both the breathing pattern as well as the vascular pulsation often lead to a less pronounced effect on the compression deformation of the lung lesions, but it provides a more pronounced effect on the mediastinal nodes. That is why the concept of EBUS elastography has come into prominence. But however, since in EBUS we use a high frequency transducer, the depth of penetration is limited, and due to the existence of the breathing exercises and the vascular pulsations, it is impossible to obtain completely identical elastic recordings. So that is why when we use an EBUS elastography, we need to take multiple imaging, and we take the mean value to understand what is the elastic pattern of the node that is being looked into. And depending upon the elastic properties of the nodes, there is a subjective classification and there are also objective classifications. So you can have a 3-color pattern which has been proposed by Professor Izumo. You can have a 4-color pattern, you can have a 5-color pattern, and you can have the Tsukuba's classification also of the elastography to understand how do you really classify whether it is a probable benign or a probable malignant lymph node. In addition to this, we also have certain objective classifications. We look into the strain ratio, we look into the stiff area ratio, and we look into the strain histogram. So when we move to the color classification or the subjective classification, the most commonly used is proposed by the Professor Izumo. So we have 3 different patterns, which is the type 1, which is predominantly a non-blue pattern, which indicates a benign pathology, and the type 2, which indicates a part blue and a part non-blue, and generally there it is equivocal, it can be benign or it can be malignant. Excuse me. And when we have a predominantly blue pattern, as you can see from the images here, if it is a predominantly blue, it indicates that it is more of a stiff node, and probably it indicates a higher chance of the node being the portion of the node being a malignant one. And before we understand the objective parameters, it all depends upon this concept of elasticity, that whenever a node is getting compressed, you feel that there is a change in the configuration of the node. And the elasticity concept is nothing but the change in the length divided by the total length, which helps us to understand which node is stiffer and which node is less stiffer. So the most common objective parameter that is used is the strain elastography. So the tissue displacement is measured in the same direction of that of the stress applied. So it can be done in 2 ways. Of course in the lung you cannot use the manual compression, but in an organ like a liver, they have tried a manual compression and looked into the elasticity of the tissue. Whereas in case of mediastinum, what we look is the changes that are produced by the physiological motions, like either in the form of a respiratory breathing pattern or by the pulsations surrounding the blood vessels. And the tissue displacement is then detected and measured. And to detect this tissue displacement, we use certain frequency like a radio frequency echo correlation based tracking or a Doppler processing or a combination of both. So the strain ratio, what I was speaking to you, is nothing but you take a node, you apply the elastography, and then you see the blue portion and you see the red portion. We know that the blue portion indicates more of a stiffer node and the red portion indicates a less stiffer node. So the reference, so what we do is we make a ratio of these two. So the reference used was a tissue between the lymph node and the bronchial cartilage. This is the reference tissue and this is the tissue of target. When you take a ratio of these two, you get a ratio somewhere ranging between 2.5 to 32, and depending upon the ratio, you try to categorize whether a particular node is being more possible of a malignant node or a more possible of a benign node. In addition to this, we have something referred to as a stiff area ratio. So what we do is we see the node, we apply the elastography, we take the lymph node area which is manually selected as a region of interest, and we calculate the pixels, and we make the color threshold adjustments, and we try to analyze in that particular region of interest how much portion is containing the stiff tissue area. So both these objective parameters has been studied in clinical trials to understand the predictability of an elastography in determining whether a node is a benign node or a malignant node. But however, when it comes to the real scenario, most of us tend to understand more of a subjective way, that is being it a green node or being it a blue node or it's a mixture of both. So what we see here is the green portion of this is nothing but a normal node, where you have got a center portion which is more of a green in color, and along with that you have certain areas of blue which is surrounding the capsular region of your lymph node. But whenever we see a node like this, when there is a more portion of the green portion of the lymph node, it indicates that the node is more elastic in nature. That means it is more pointing towards a benign etiology. And as you can see from here, this is another case of an inflammatory lymph node in a sarcoidosis, which consists of a softer hilum. So the more soft it becomes, the more greener the presentation of the lymph node in terms of your elastography, and the red region represents and the blue region represents a stiffer area. But when we go to a malignancy, you can see from here the center portion of the node has been replaced by a more stiffer portion of the lymph node. That is why you get more of a blue coding in comparison to the green coding. And when you have a node which has been totally infiltrated by means of a malignancy, then you get almost a complete node which has been colored blue. And in addition to this is another case of a diffuse metastatic infiltration. You can see that there are large portions of a stiffer node with few areas of with elastic node, which indicates that there is a more malignant infiltration of the lymph node. So how is it going to really help me in my clinical practice? One, when I do an EBUS elastography, I can have a predictability whether I am dealing with a case of a benign node or a malignant node looking into the elastography. Another thing, if I am going to take multiple passes and my pathologist in rows keep on saying that she is just able to see a reactive node, then to choose a site where I have to really pass my needle, then I can use an elastography. Let's say that I have been trying my needle passes multiple times from this green region. Now I use an elastography. I see a stiffer portion of the lymph node. Now I pass my needle into the stiffer portion of the lymph node. Then probably I am at a higher risk, higher chance of getting a positive node for metastasis or for a malignancy. So this is why we generally use an elastography in a routine clinical practice, but just mere presence of a stiffer node or a less stiffer node will not confirm whether it is a malignancy or a benign. You need a tissue confirmation, and this can just guide us in understanding what sort of node we are dealing with and how are we going to triage our samples and to choose the target site of the node for FNAC. And with respect to the evidence surrounding the EBUS elastography, there has been a systematic review and meta-analysis trying to use the elastography techniques to differentiate the malignant from the benign nodes. It is a wide, I'll just put it in a nutshell. What they found was the sensitivity in differentiation was as high as 90%, but the specificity is only 0.79, which means that even if you get a negative elastography favoring a malignancy, you can still have a malignancy. And what they found was the type 3 pattern, which is more of a blue in color, over the green pattern, which is the type 1 pattern, suggested that the node tend to be a malignant lymph node on a subsequent TBNA sample. So ultrasound elastography is useful in differentiating the malignant and the benign lymph nodes during the routine EBUS TBNA. However, elastography will not or should not replace the requirement of the lymph node aspiration. In addition to this, in India, the major difference that we see is between the tuberculosis and the sarcoidosis. So our Indian colleagues have tried to understand whether this elastography will be helpful in differentiating a tubercular lymph node from a sarcoidosis lymph node. So what they tried to do was they tried to see if the type 1, they tried to label the type 1 as sarcoidosis and the type 3 pattern as tubercular, then the sensitivity was only 48% and the specificity was only 55.6% and the negative predictive value was only 66.7% and the positive diagnostic accuracy was only 0.51, which means that your color coding cannot clearly differentiate whether you are dealing with a sarcoidosis node or a tubercular lymph node. They also tried to understand the strain ratio. What they were able to find out was the median strain ratio was 1.29 for a node with a sarcoidosis and the median strain ratio was 2.10 for a node, 1.29 for a node with tuberculosis and 2.10 for a node with sarcoidosis. However, they had to conclude that the ultrasonographic elastography lymph node characteristics had a poor predictability in differentiating a TB and sarcoidosis. So as on date, we cannot differentiate using an elastography whether we are dealing with a case of a tuberculosis or a sarcoidosis, but it helps us to understand better whether we are dealing with a malignant node or a benign node. But a histopathological confirmation or a cytopathological confirmation is mandatory. The another utility of elastography would be to target the site of a node if you are getting multiple passes, which is negative for malignancy. And this is just for information. On July 29th and 30th, we will be conducting a rigid bronchoscopic workshop. So people who are interested can join us. Thank you.